Welcome to Prairie Health and Wellness. How many people have never been here before? Oh, wow.
Oh, my.
Wow. Well, welcome. That's fantastic. I'm Dr. Kristen Marvin, and I'm the naturopathic doctor here in the office. And this lovely lady over here to my right, or your left, is Jolene Zivnuska, and she's our amazing nurse practitioner. And then the man in the back here with the blue scrubs on is Dr. Jeffrey Davis, and he's another awesome healthcare provider here in our office. So I'm glad you guys came by this evening. I know the weather's pretty nice outside, or at least it was the last time I was out. And tonight I'm going to be talking about irritable bowel syndrome, and maybe even a little more so on a condition called SIBO, which stands for small intestine bacterial overgrowth. So we'll just go ahead and jump right in and get started. First and foremost, I want to give acknowledgement to these four doctors that I listed up here. These are doctors that are really big in this area of research, and I'm going to be presenting on a lot of their information and things that I've learned from them. So I figured it was easier for me to just give credit where credit's due right initially, instead of trying to individually pick out as we go along. It'll just make the flow go a little better. So another place I like to start with whatever topic I'm discussing, whether it's here in the office in a presentation setting like this, or in a office visit in the room with whatever or whoever patient I'm working with, is it's important to understand the basics of what we're talking about. So when I say terms like small intestine or the stomach or the large intestine or the colon, we kind of have an idea of the area that I'm talking about. And so I'm sure many of you are familiar with the gastrointestinal tract and understand that it has many complex functions, and they all work together to essentially break down, digest our food, absorb nutrients that we need from food in our diet, and then also be able to eliminate. We need to get rid of the trash or the garbage that's left over from that process. And as Jolene always says to our patients in visits, is that it's really important that we take out the trash every single day, right? That's really important function of that too. So not only is this just a mechanical situation that takes place, but there are also hormonal actions that play into this. And we'll go ahead and move on to the next page here and look at another piece of anatomy. But starting at the top, we put the food in our mouth and we start chewing it. And that's our salivary glands are going to be activated, and they're going to secrete enzymes that start breaking down our food right off the bat. And so once we swallow and food moves down into the esophagus, it's essentially just the transport tube of getting those food materials into the stomach. That's where we have additional chemical breakdown, more enzymes play a part in that. The acidic environment of the stomach is very important. So a lot of times we want to identify if someone is producing enough stomach acid. We actually quite a bit work with people who come in that are on acid blockers, proton pump inhibitors, because we think maybe there's too much acid production. And sometimes that does happen. But a lot of times what we find is that really people are having acid reflux and heartburn because the stomach acid is just really getting to a place where it shouldn't be. And so we have that unpleasant symptom, which can also be very damaging to the esophagus. But it's about finding a good balance and trying to determine why are we having that symptom. It's not always necessarily an overproduction of acid. So that's something we like to address and think about as well. So we also have the liver and the gallbladder that play a big role in digestion. The liver produces a substance called bile, which is really important for digesting fats that we eat in our diet. And the bile that's produced in the liver is then stored in the gallbladder. So the gallbladder is a nice little storage compartment so that when we eat and our system detects fat from the foods that we're eating, our gallbladder will start to contract, and then we get that bile that gets placed into the very top of the small intestine, which is the next place that the food goes after it's left the stomach. So the pancreas plays a role in that too. We definitely get some digestive enzymes from the pancreas. And then we start the long track down the small intestine. So the small intestine is kind of bunched up in the middle there, but if we were to extend that, it's a very great distance. And so after we travel through, there's 3 parts of the small intestine that I'll be addressing and talking about this further on in the talk. We then move into the large intestine. And so really with the small intestine, what we're doing, the food that's been started with this digestive process, we're starting to then extract and absorb nutrients from our food in this area. So once we get to what's left in the large intestine, that's when we're really starting to pull a lot more fluid and liquid from that matter. And that's when we start to really form this stool that then we're going to eliminate. So that was kind of a quick tutorial of just that process starting from the mouth and going all the way through. And so I'm going to get a little more specific, but again, kind of going back to when I was talking about the importance of, as Jolene says, taking the trash out every day. We want to make sure everyone is pooping every single day. So that's really important that we do that. So I thought this would be a perfect lecture, since we're talking about the gut and digestion and that type of thing, to put that information out there, because sometimes not a lot of us know that we really should be having a bowel movement at least every day. And for that matter, how many times a day should we be having a bowel movement? So theoretically, we should all be having a bowel movement about 30 minutes after we have a meal. So most of us eat breakfast, lunch, and dinner. We should really be a good, healthy, functioning gut. We should be having a bowel movement about 3 times a day. You know, we have this reflex. It's called the gastrocolic reflex. So this is a reflex in response to food in our stomach. And then as it moves into the small intestine, we have this reflex to the colon that essentially is just saying we need to make more room for what's going to be coming down the pipe in a little while. If people aren't having a bowel movement at least once a day, we talk about things we call bowel training. And so perching, we call it perching, going to your bathroom and perching on the toilet about 30 minutes after you have a meal is just a good way to kind of get your body into the mode of, okay, this is what I'm supposed to be doing. It's like practicing. Now, that doesn't mean you have to stay there until you have a bowel movement, but just getting into the routine can actually kind of trigger signals to your body that this is what I'm supposed to be doing. So another wonderful thing, and this is actually where I got this I like this picture, I think it's kind of funny. The squatty potty is another thing that we recommend quite a bit, because the position when you're taking a bowel movement makes a big difference too. Mainly because of our anatomy. So kind of going back to the large intestine, the rectum, and then the anus, where we're having a bowel movement, eliminating. When we sit and our knees are really at a 90-degree angle, or some of these houses I've seen now where the toilet is higher off the ground so you don't have to sit down as low, we're actually not putting our intestine in a good angle or the most efficient angle to have a bowel movement, an easy bowel movement. We're actually kind of putting a kink in it. So the stool essentially has to almost go around a corner when we're in that position. So the squatty potty is nice because it elevates, not this high, but it elevates your knees so that your knees are actually above your hips. And when we do that, it tilts our pelvis in a way that the intestines actually are a nice straight line, essentially. So we're not fighting to get around this corner. So the squatty potty is awesome. I think you can actually get them at Bed Bath & Beyond, but if you have some old phone books laying around, you can use phone books. You can get creative. You don't necessarily have to purchase a specific product, of course, but so wanted to take the opportunity to really talk about that. So another thing that's really important, which I'm sure many of you have heard about, I feel like this is a pretty hot topic in medical news recently, is our microbiome. So we know that our bacteria in our body outnumber our human cells 10 to 1. And we're talking trillion, not 10 to 100. We're talking trillions of bacteria. So I have to give credit to my husband for this, but he said, so maybe we're actually just a bunch of bacteria having a human experience. And they're doing a lot of exciting research in this area right now. We know our bacteria plays a large part in our immune system. hormone metabolism, and the list goes on and on. For our talk today, I wanted to bring up this bacteria because of some of the symptoms that are associated with irritable bowel syndrome or maybe SIBO, which we'll get to here shortly. How much bacteria and where that bacteria is located really does matter. So if we start at the very top of the tube, we really don't have much bacteria when we're kind of towards the top, or when I say proximal, that's what I mean is the top. And then as we move further along distally, we gradually start to get more bacteria as we go along. So I listed here with where it says bacteria count, the duodenum, jejunum, and ileum. Those are the three parts of the small intestine. And so really there's very few, if any, bacteria in the duodenum, which is closer to the stomach. The middle part has a tiny bit more. The ileum, or the part that's closest to the large intestine, has a little bit, but really in the grand scheme of things, it's our large intestine where the majority of the bacteria should be located. So we're going to talk about some reasons why a potential overgrowth or that bacteria can get to locations where it really shouldn't be, and how that kind of plays a part in some of those symptoms. So really the small intestine, I talked about earlier how that the food moves through, we're absorbing nutrients. It's really described more as a liquid bath that moves quickly throughout that area. And really quickly is a term that we can use loosely because the distance of that small bowel really is quite great. So, again, just emphasizing the importance of we need the acidity in our stomach. We need the digestive enzymes, bile from our liver that's stored in the gallbladder. We need a good healthy lining and a very high diversity of bacteria. These are all key components that play a part of this healthy intestinal place. So let's talk a little bit about irritable bowel syndrome. So we know really how it's defined is actually a disorder of the large intestine. So common symptoms include cramping, abdominal pain, bloating, gas, and then diarrhea and or constipation. So I say and or because sometimes people go back and forth between the two. And so it is because there aren't typically any physical signs that we can then definitively diagnose IBS or irritable bowel. We usually diagnose it as we're ruling out other things that we're looking for. So things like Crohn's disease or ulcerative colitis. Sometimes people have diverticulitis. There are a number of different bowel-related conditions that we really want to rule out first. And if we can't find anything and people are still experiencing these types of symptoms, usually gets kind of thrown into this diagnosis of irritable bowel syndrome. So there is a set of criteria that's used to diagnose this, and it's called the Rome criteria. And so what that consists of is that someone who has abdominal pain and discomfort that lasts at least 3 days a month for the past 3 months. And then there's typically 2 or more of the following symptoms. People will have an improvement in their symptoms when they have a bowel movement. And then there's usually your stool frequency is altered, meaning maybe some days you have multiple bowel movements, and then some days you go maybe days without having a bowel movement. And then also the altered consistency of the stool too. So, basically constipation versus diarrhea. Is the stool well formed? Is it really hard and dry? Is it very loose or watery? Those are the different characteristics that we're looking at when IBS is diagnosed. So here at our office, we really try to get to the root cause of what's going on with whatever people present with. Sometimes we do offer to treat symptoms because we want to provide some relief, but our main goal is always trying to get to the root cause and figure out. And so this can be really difficult with something like IBS. So things that we consider, always looking at genetic components. Is there a recent infection or trauma? So, trauma can even be something, have you had a surgery possibly? And so some symptoms appear to result from disturbances in colonic motility. So, talking earlier about how we should have this reflex, we should have what's called peristalsis, where we're having this normal movement through the GI tract is really important. So sometimes people have increased sensitivity to food, obviously gas or stool in the intestines. Other things to consider, we know that there's a strong connection between the brain and the gut. So how many people have an upset stomach when you're really nervous about something? Or my embarrassing story when I was a medical student of being so stressed out about this anatomy lab exam that I have that I'm like sprinting to the bathroom when I'm supposed to be, you know, in the lab taking the test. So we know that there's a strong connection there between our brain and our gut. And so kind of again, going back to, is it this gut bacteria that might be at a place where it shouldn't be? So how do we treat IBS? A lot of times, especially in conventional medicine, we just treat the symptoms because again, we've tried to rule out, is it something, you know, is there some kind of serious pathology in the gut? And so when we don't find that, we say, okay, it sounds like IBS and here's what you can do for your symptoms. We're not really getting to the cause. So dietary changes are typically recommended, and also medication. So things like fiber supplements, which can actually make people's symptoms much worse. I'm sure some of you have experienced that by taking fiber supplements. If you have diarrhea, here's a medication to try to stop the diarrhea. If you're having cramping, pain, what's called an antispasmodic. Sometimes, you know, going back to that gut-brain connection, we suggest, when I say we, I use the term loosely, we typically here wouldn't jump to something like an antidepressant for this type of condition, but it is recommended. And antibiotics. Sometimes doctors will just recommend using antibiotics to treat this. So again, our question always is, are we addressing the cause? We work a lot with people, and I'm sure both of my colleagues, you know, we talk, well, you can try this for this or this for this, but we always usually pause and say, are we really addressing the cause? Or are we just, you know, we do integrative medicine, and some people view that as, oh, well, I like to go to them because they give me natural options. But even with natural options, while they're nice and they can sometimes be helpful, it's always really important to go back to, are we addressing the cause of what's going on? So we're going to transition a little bit into small intestine bacterial overgrowth. So IBS, or irritable bowel syndrome, is something that affects a good percentage of the population. It's estimated that up to 50% of gastrointestinal related visits are related to an IBS type of a picture. And now we're learning that up to 60% of those visits may be due to this small intestine bacterial overgrowth picture. So again, going back to the cause, so we identify that maybe the bacterial overgrowth is there, but how did it get there? Because we can't just say, oh, well, it's just overgrowth of bacteria, let's just kill it, and that should take care of it, right? But how did that happen? Why did that happen? That's actually probably the most important part of treatment, is trying to identify that so that we can try to correct that. So when we do go to address this situation, the idea is to prevent it from recurring or happening again. So that's a really important part. So we'll talk about some of the ways that we think that this SIBO picture can happen. And a lot of times people will have a history of a type of gastroenteritis or infectious cause in their history. So, oh yeah, I had food poisoning when I traveled wherever, and I haven't been the same since. So again, kind of looking at a timeline here, there's usually some inflammatory process that happens. Because of this bacteria, and what happens is damage to the lining of the small intestine. The cells of our small intestine produce what's called a disaccharidase, and there are a number of different disaccharadases, which essentially are just enzymes that can break down different types of foods in our diet. And so when we don't have those, I made a little note that we're going to get more into the details of that here shortly, but when we don't have those enzymes that we need, that just gives the bacteria that's there more food to digest, and they start to ferment and produce gas. And we're thinking that that's where a lot of this gas and bloating is actually coming from. So, again, that kind of went right into the next slide there. Those unabsorbed, really undigested carbohydrates really help these bacteria then just proliferate and grow. So when we're thinking about, is small intestinal bacterial overgrowth a possibility, Gas and bloating really are key symptoms with this. If someone says, no, I really don't have much gas or bloating, then that's really a big clue to me that we need to look somewhere else. Because really it's the bacteria that are fermenting these things and producing all this gas and bloating. So I try not to ask leading questions, and probably the most common things people will say to me, I have multiple people say to me, I look pregnant, I feel like I'm 6 months. It's usually like a 6 to 8 month pregnancy description that I get. Everything I eat makes me bloated or gassy. Other things, I feel better first thing in the morning, and then as the day goes on and I'm eating food, my symptoms get worse. So that's another common thing. And then again, with the diarrhea and constipation, those are really common symptoms that we hear with this type of condition. And really, this is just a cycle that just keeps going and going, because again, we haven't really addressed the cause quite yet. So other symptoms sometimes that people will present with in their history, they'll say things like, actually, I had to take an antibiotic because I had some dental work done, or I had a tooth infection, or maybe a sinus infection, which we really don't like to give antibiotics for, but sometimes these things happen. And I had to take it for this, but I noticed while I was on the antibiotic, my gut symptoms actually felt a little better. Because sometimes there are a number of different antibiotics that we'll talk about in treatment options, that really is the first part of treatment. It's not the only part. Sometimes people will say, I thought probiotics and prebiotics were supposed to be good for everyone, but when I take them, they make my symptoms worse. That's another key thing with this. If you do have to take acid reflux medication or something like a proton pump inhibitor, an acid blocker, they can cause your symptoms to be worse. And a lot of times people will say, I feel like I burp or belch more when I use those. A very few amount of patients that have celiac disease or gluten sensitivity, when they totally eliminate that from their diet and they're still having symptoms related to that, sometimes that can give us a little clue that there's still something not quite right there. And then another very common thing, going back to, I probably should have put this where I was talking about common causes, but when people have to go on maybe pain medication after a surgical procedure and they suffer from constipation, it's something that's very common. So sometimes people will say, oh yeah, I had this surgery, I was on pain medication, became constipated, and I've not been the same since. So these are just some of the other things we look for during your appointment or intake. So there are also some other related conditions to small intestinal bacterial overgrowth, which I won't go too much into, but things like an H. pylori infection, leaky gut, which I'm glad that that's not really what happens when we have a leaky gut. That would be a bad thing. That's a great question. Can I save your question for towards the end? Yeah, that's a fantastic question. So sometimes people will have fibromyalgia, acne. Sometimes people can have Crohn's or ulcerative colitis with this. So these are just a few. The list is much longer, but just related conditions that can happen with this. Okay, so you think you have SIBO, or this sounds like, oh, I'm connecting with some of this stuff. So what do we do next? So a comprehensive intake is very important. Again, knowing your history, trying to go back and identify the cause. Right? That's something I can't emphasize the importance enough of. There's testing that we can do to evaluate this type of situation. There's a very comprehensive, detailed treatment plan as far as treatment options go. And then I also want to talk about what maintenance looks like, which I'll get into towards the end, and I'll say now. It's probably one of the more difficult conditions to treat. The chance for relapsing or going back to having similar symptoms is very common when we're addressing something like this. And so our goal is to really get people to a place where you feel comfortable, you feel like your symptoms are improved. But I always want to give people realistic expectations, in that just because you complete the treatment plan and you're doing really well, it doesn't necessarily mean that this can't happen. This type of thing can't ever happen again. So I want to stay positive and say, we can get you to a good place, but The maintenance is really, really lifestyle changes, which we'll talk about. Okay, so what does the intake look at? Again, we want to look at the onset, what was going on around the time that, or maybe even slightly before where you started experiencing the symptoms. Is there any history of food poisoning, like I mentioned, chronic antibiotic use, any other gut conditions that you've been diagnosed with? Have you had any recent surgeries? So even something like delivering a baby via C-section can contribute to something like this. Is there any family history, significant family history? Maybe there's a genetic component, or maybe there's some other type of autoimmune disease that we need to look at. Analyzing a diet diary is really important. And so I would encourage everyone, anywhere you go, and maybe your doctor won't ask you about diet, but if they do, try tracking your diet a few days before you go have an appointment, because sometimes that can give us some really good information. So a few reasons that we want to analyze someone's diet diary or look at what you're eating. We want to be able to evaluate your overall nutrient intake to see if you're potentially lacking any nutrients that are vital for healthy gut function. We want to see, are most of the foods you're consuming, do they tend to be a little more pro-inflammatory, or do you have a pretty good anti-inflammatory diet? So we want to be able to look for common gut irritants like coffee, alcohol, junk food. And we were at a conference recently, and I felt like someone described junk food really well. They said, there's no such thing as junk food. There's junk and there's food, right? So, so that's definitely something to think about. We want to see what the majority of your diet, what your intake is like. So what does your macronutrient balance look like? What's your ratio of carbohydrates to fats and to proteins? Can make a big difference. And then even how frequently do you eat? Are you a grazer? Do you snack throughout the day, or are you pretty solid for 3 separate meals? That can all play a role in actually your gastric motility, which we'll talk about here a little bit more too. So sometimes we'll recommend some additional blood work or imaging. Blood work from the standpoint of trying to maybe identify any potential micronutrient deficiencies. When our gut is not functioning optimally, we are at risk for not absorbing things as well, and we may be missing out on some key micronutrients like different vitamins and minerals that we need. So ferritin or iron, D3, magnesium. I put micronutrient testing with a question mark because we do have a micronutrient test here that looks at all the different vitamins and minerals from that standpoint. Should you be tested, and should we consider something like celiac disease? Because some of those symptoms can really overlap with, the presenting things that we talked about initially. Imaging is not always necessary, so that's usually determined based on your intake. Do you have any concerning or alarming symptoms or signs? So if you say, I've had really dark stool, or I've noticed blood in my stool, that may warrant some additional imaging or additional testing. So those are things that we'll start with to evaluate. We'll also look at food sensitivity testing. So usually what we're looking at from that standpoint is we're evaluating IG stands for immunoglobulin, which is a part of your immune system, and we have different immunoglobulins. We have immunoglobulin G and A. Those are the 2 most common ones that we look at. G is more of a delayed response, so sometimes that can be helpful when you're trying to identify foods that may trigger unpleasant symptoms, because sometimes what we find is people will consume something and you won't have a symptom until a day or 2 later. And that can be really difficult to figure out because sometimes I'm trying to remember what I had for dinner last night, right? So a blood test can be helpful. It's not necessarily the gold standard. Really, the elimination diet is the gold standard, but this blood test is kind of the next best thing to help provide some guidance. So really why we want to do that is just to identify, are there any potential food triggers of your symptoms? I put a little side note here. The next test I'm going to talk about is a breath test, and that's really what we use to diagnose if there's a small intestine bacterial overgrowth. So if that is positive and that indicates that you do have that, that trumps the food sensitivities. A lot of times what we find is if we can correct this small intestinal bacterial overgrowth, that you don't seem to have some of these, or you don't seem to react to some of these foods that we would maybe typically classify as a food sensitivity. The other reason with that is that the diet part of the healing protocol with treating SIBO can be pretty limited initially. So the last thing we want to do is put you on a somewhat limited diet that's only temporary as you're going through this healing phase, and then say, well, it's limited, and now we're going to take these away because you tested positive to them on your food sensitivity test. So the breath test, just kidding. The breath test that I'm going to talk about in the next slide after this one trumps over a food sensitivity test. But that may be something that we recommend looking at. So stool analysis is another thing we may recommend to look at. It's called a comprehensive digestive stool analysis. We're going to be looking at different inflammatory markers in the gut. How well are you digesting your food, because it can identify if you have meat or vegetable fibers that have been undigested. We can look at the different types of bacteria that's in your gut, so it can help tell us if you have maybe a dysbiosis or an imbalance of the good bacteria in your large intestine. It can't be used to diagnose this small intestinal bacterial overgrowth, because the stool is really, we know it's just what comes out at the end. It doesn't really tell us, oh, this was in this part, this was in this part. It really tells us what just eventually got to the stool. So it has, the bacteria that comes out, there's bacteria that's dead and also some bacteria that's still alive that we can culture out, but it really can only show us that. It can't tell us if you have this overgrowth of bacteria in the small intestine. Another thing it can help us determine if you maybe have candida or yeast growing in your stool. We all have yeast as part of, beneficial yeast as part of our normal microbiome, but sometimes if there is a large amount that's identified in the stool, that would require some balancing to take place. And this, having yeast in an overgrowth of yeast in your stool, can lead to some of these similar symptoms that we've talked about. So that can help determine if we're maybe even dealing with something like that, alone or in addition to the bacterial overgrowth. So now we can talk about the breath test. So this is really the test that we recommend in the office when we're considering is SIBO a possibility. So there are 3 SIBO gases, and the first one being hydrogen, the second one being methane, and the last one being hydrogen sulfide. So what we're measuring with the breath test is the presence of hydrogen and methane. So hydrogen sulfide gets put down at the end because we can't actually measure the hydrogen sulfide, but sometimes we'll get a test back that has very little hydrogen and very little methane, but people still really have a lot of gas and bloating. So some of the key symptoms with this is that people with hydrogen sulfide overgrowth tend to have more diarrhea, and their flatulence may smell like sulfur or rotten eggs. So not necessarily, maybe something that we all kind of joke about and play around with our families or close loved ones. But for someone, so I don't just ask that question in the appointment to be silly. I'm actually being serious. I want to know this. This is good information. So with hydrogen, that tends to go more with a diarrhea dominant type picture. And with methane producing bacteria, people tend to be more constipated. So sometimes we can even try to make an educated guess based on which way you'll fit with your breath test based on this. It's not always that way, but a lot of times we do see the gas and the relationship with either constipation or diarrhea, for that matter. So the breath testing, how do you collect your breaths? We take blood from people, you collect your stool, your urine. How in the world do we test breath? So it's collected in tubes. The kit comes with this apparatus where you blow and inflate this bag. And then there's a little puncture site where we push the tube, and the gas then gets sucked into the tube. So we start with just an initial baseline tube, and then to see where you're at with nothing in your stomach or your digestive tract. And then we have you drink a lactulose solution. So this is essentially the food that's going to feed these bacteria as it moves through your digestive tract. And so the bacteria then feed on this lactulose solution, and then they start producing the gases. And that's really what we're measuring, is the production of that gas when you drink this lactulose solution. So this test does require some prep work. There's about 2 days of a specific diet they want you to follow. And the kit comes with very good instructions and sample diets and things, so it is a little bit of extra work than just going home and collecting your stool, but can give us really good information. The timing of the collection of the tubes lets us know where you're at in the digestive tract as that moves along. So we spend quite a bit of time in the office going over the collection instructions with that, because that's a really important part of testing. So really, I always like to, I mentioned the gold standard test with with identifying food sensitivities. The gold standard test for identifying an overgrowth in the small intestine is actually a duodenal and jejunal aspiration. So what in the heck does that mean? So essentially, this is a very invasive, somewhat surgical procedure that typically occurs during an endoscopy, where they stick a scope down your throat and we get in and look at the stomach, and we can get into the small intestine. So they essentially take a sample, or what's called an aspirate, and then they pull it out and send it off to the lab to culture it to see if there's an overgrowth. So I don't think we've ever recommended this. I don't think I would necessarily recommend this, just because it is super invasive, very expensive. Exposure to the air when they're pulling out the aspirate can actually compromise the culture or the bacteria that's being collected. So the breath test sounds much nicer versus this. But always important to give you all the options that are available. Okay, so now let's move in and talk about some of the treatment options. I'm going to keep this very general. If we were sitting together in an appointment, I would spend a lot more time, we'd go into a lot more detail. So first step is we do need to eradicate or eliminate the bacteria in the parts of the gut where it's located. So I'm a naturopathic doctor, so antibiotics is on my list of things that we pull out when they're appropriate. I do, thankfully we have those things. And for this type of a situation, the good thing is we have some really good options from an antimicrobial standpoint. So once you choose an antimicrobial protocol, which I'll talk a little bit more about, it's ideal if we can repeat the test, because we really want to make sure that we've corrected this overgrowth picture. So I understand that some of these tests can be a little on the pricier side, and so sometimes we find compromise, and if we all understand, we're all on the same page as far as what are the potential risks versus benefits. Sometimes we can move forward with treatment, but it really is ideal to make sure that we've taken care of that overgrowth of bacteria. The other thing, again, to try to stay on the positive side, this is a very difficult condition to treat, so sometimes people do have to do more than one round of antimicrobial therapy. So the options for antimicrobials, Alsaxamin or Xifaxan, it's typically dosed for about 2 weeks. It's something that you take 3 times a day. It is a prescription antibiotic, but it actually, when we're talking about antibiotics, this one actually has some pretty good data behind it. As far as it has a very low resistance potential, so the ability to develop this antibiotic resistance with this particular drug is actually very low, because of how it works to kill the bacteria. It's very effective against those hydrogen producers that we talked about. Another key part is that this medication is not active in the colon or the large intestine, and that's where, again, the majority of our good bacteria is at. So that's the bacteria we want to be protecting. And so they've studied this drug, and they know that it's not active in the large intestine. So to me, that's something that makes me pretty happy. So again, more studies show the safety of this antibiotic. There's actually some study which would be a benefit for women, obviously, that it can improve your vaginal microbiome. It can increase short-chain fatty acids, which are good nutrients that we need for a healthy gut, and really overall has pretty low adverse side effect profile. One of the downfalls of it, it is a little bit on the pricey side, but we have options as far as that goes that we can talk about. Sometimes depending on the type of bacteria that you have, if you're a hydrogen producer versus a methane producer, the methane producers tend to respond better with multi-drug therapy. And the way I'll kind of describe this to patients is, if you've ever had or been diagnosed with an H. pylori infection, they're using multiple antibiotics to treat that, along with a few other things. So sometimes for these more difficult bugs, we do need to use more than one therapy to attack that. So again, with these drugs, the side effects, with any drugs you go and you read the little back of the label with the side effects, and sometimes there's some concerning, scary things listed. With these particular drugs, they are unlikely. We're using this for a short period of time, only 2 weeks, and that's obviously something we would be monitoring as you were going through treatment. So we do have natural antibiotic options, and where that differs is really with the treatment length, or the length of time for treatment. So instead of 2 weeks, it's usually about a month. So sometimes people prefer to start with the natural options, and that's totally fine. That's based on personal preference. Or sometimes people will try it when the prescription antibiotic therapy doesn't work. So we do have a nice study that was done at Johns Hopkins that did find that the natural antibiotics, or anti-natural microbials, were pretty comparable in treatment when they tested it against a group that were treated for this with the prescription, the rifaximin. With the natural antibiotics, these are also pretty expensive. They can get expensive, so that's something to consider too. So just to do a quick pros and cons, how we help people decide which treatment protocol they'd like to go with. For some pros for the prescription would be that we have good scientific data to show that they do work. Sometimes your insurance company will pay for this expensive medication, or we also have a cost-effective option that you can get through Canada that's still a good quality medication, and the pro of only having to use it for 2 weeks compared to maybe 30 days with the natural choice. So some of the cons, the delivery from Canada can take some time, so that can delay the initiation of treatment. So that's not necessarily a positive thing. And it can take, again, multiple treatments for this to work. So that would be not great. One time would be a good thing. So for some of the natural antibiotic treatment, having a natural option is ideal. It's nice. It's a nice alternative. We do have a very small amount of data to support that it may be just as effective. But some of the cons would be it can still be expensive. The natural antibiotics don't have that perk of only staying in the small intestine. So sometimes people can have upset stomach. We can't say that it's not active in the colon, like the rifaximin is inactive in the colon. Sometimes you have to take multiple natural or a mix of natural antimicrobial options. And again, just the length of treatment time for this one would be a con because it is a little bit longer. So additional parts of treatment, we look at probiotics. So probiotics have been shown to help reduce diarrhea, which would be particularly helpful with the hydrogen producers. Another thing we recommend during antibiotic treatment, is partially hydrolyzed guar gum. So partially hydrolyzed is not the same thing as partially hydrogenated. So I want to clarify that. They do sound similar, and that should turn a lot of us off when you see anything that says partially hydrogenated, but not the same thing. We essentially have a very simple carbohydrate complex. And so this has actually been studied to show that it makes the antimicrobial therapy more effective, because we want those bacteria to be eating and taking in their surroundings, what's in their environment. And if there's an antimicrobial there, we want it to be taking that in, because that will make the therapy more effective. So sometimes people can have nausea with this treatment, and so something like slippery elm, which is a good natural supplement that can help with that particular side effect We have a great product out here that has slippery elm in it that people have given good feedback on during this time. Okay, so let's talk about diet. This part is probably one of the more complicated parts of treatment. And we don't start these dietary changes until after the antimicrobial therapy. Because again, we want those bacteria to be we want them to be well fed. We want them to be, taking in that antimicrobial treatment. So there are 3 diets we're going to briefly touch upon. And again, I'm going to keep it brief here, but I have a lot of helpful handouts because a lot of this stuff with the diet is not always as intuitive or easy to adapt to. And so if you were to go through this type of protocol, we give you a lot of resources to use. But again, I'm just going to keep it a little basic for tonight. Because otherwise we'll be here until midnight talking about some of these dietary options. So the first one I'm going to talk about is called the Specific Carbohydrate Diet, or the SCD diet. And so maybe some of you have heard of this. It was originally created for children who had inflammatory bowel conditions. But again, it really is currently recommended for multiple GI conditions that people have. So again, kind of going back to, we know that the cells that line the intestine contain these disaccharidases, these enzymes. I've listed a few of them here. We need that to, again, break down and digest these certain carbohydrates that we're taking in. So if we don't have that, if that process is broken, then while we're going through the healing process, it's optimal to eliminate these foods from the diet. Because most people will find that their symptoms get worse when they consume some of these things. So it is somewhat similar to the paleo diet in the sense that the majority of the initial starting diet, your intake is going to be coming from things like animal protein, nuts and seeds. So a small amount of vegetables are initially introduced, but it's preferred that they're cooked and peeled. Again, we're just trying to make this digestive process as easy as possible. So when I give people the initial, first part, it is a limited selection, and I give lots of encouragement and say, don't worry, we're going to gradually introduce things as we go along. Because again, it's much easier to slowly add things than it is to just overwhelm your system after we've just created this good environment. Yes?
Is this really similar to DAX?
Yes, that's the one I'm going to talk about next.
Okay.
Yep. So the specific carbohydrate diet was developed first. And so again, this is just an example of something that I would give you in the office. Shopping lists are helpful. Sometimes people like to see things that they should avoid versus things that you should, choose. So again, this is just one example of a list I may give you an appointment in the office. Okay, so GAPS diet. GAPS stands for Gut and Psychology Syndrome. So this was developed after the development of the specific carbohydrate, and it's very similar. Some of the bigger differences would be that when I just talked about the SCD or the specific carbohydrate diet, we really encourage that you cook, peel. This diet, that's not a very important part of this diet. It's really that we're consuming more vegetables and fruits. They can be consumed raw. They encourage them to be juiced, so there's a lot of juicing. The majority of the daily intake is, again, kind of similar to the first diet we just talked about, a lot of meat. One difference would be fermented dairy and fermented vegetables. And another thing that the GAPS diet really encourages are broths. So more specifically, bone broths. So bone broth is actually something that we recommend to quite a few people when we're talking about gut health. Very helpful for healing, very anti-inflammatory, very immune supportive. So again, we really recommend that we all consume something like this daily. And we have a great website, or we have a great recipe on our website. So that's something I can share with you. I think maybe did we grab a list that we can pass around for people to write emails if they want? Oh, perfect. Okay. So this is something that I can email to you if your email's on that list, recipe. Recipes are not hard to find. There's actually a product that's available in the store. I think the brand is Pacific. and they've actually started making bone broths. That's the key part of that. You want to see it say bone, so not. It's not good. Okay, we have one review here, so just better to make your own.
I'd rather do this from scratch.
Okay, that's good. Good feedback. So I think it's better. I mean, I'm a big fan of making things at home on your own because you're really controlling what's going in that way. So really, you can cook soups with this, or you can just heat it up and put it in like you would be sipping a cup of tea. So I think a cup a day is a great basic place to start. So the last diet to talk about, and actually this diet is the one that has more research and studies behind it, is a low FODMAP diet. So FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So that's a mouthful. It's a mouthful, and to be honest, even for someone like me who's really studied a lot of this stuff for a very long time, it's not intuitive, or maybe I'm not as smart as I like to think I am sometimes too. But with that being said, again, we've got lots of helpful handouts to help with this. So, things like, so for the F, we want to avoid things that are fermented. The O, the oligosaccharides, that's going to be things like wheat, garlic, onions, barley, rye. Those are some examples. The disaccharides, thinking of lactose, we're all familiar with that term. So dairy products. M, the monosaccharides are going to be coming from certain types of fruits, things like different types of sugary syrups. And then the polyols, more, again, found in certain types of fruits and also sugar alcohols. So again, this one's very complicated. It's not as intuitive. You see one vegetable, it's on the approved list. Okay, how is this different from the vegetable that's on the avoid list? Well, it's kind of tough because there's not really trends that we can follow. However, despite its difficulty to maybe adapt to from plan on spending a little more time reading labels in the grocery store, right? We get pretty good results. We have good data that people have an improvement in their symptoms when they follow a low FODMAP type of diet. So just again, an example of things that are high FODMAP food sources. So lactose, that's kind of an easy one. Some of the softer cheeses and custards. So I know Julie did a great job of picking out some hard cheeses that would be, better from that type of food choice. Looking at the different fruits that have more fructose in them. Some of the things with the fructans and the polyols. So you can just see, just by briefly looking at this list, that there's really not an easy way to follow some of this. So again, lots of handouts are given during these appointments for support. So obvious benefits from changing the diet: anti-inflammatory, people get improvement in their symptoms. Weight loss or metabolic efficiency can be a positive thing for some. You may be able to stop prescription medication that you've been on, and then the obvious of just an improved health or quality of life. So some of the drawbacks, change is difficult. We all know that, especially with the diet. Eating out may be difficult. It's hard to choose exactly what goes into your plate when you dine out. Meals with friends and family, we get invited to things, so it can make social situations a little more stressful. Eating while traveling, which is already difficult to make healthy food choices when we travel, so that could be a drawback. More cooking at home. I get a lot of feedback from people that they don't like to cook, they don't like to spend time in the kitchen, and I think that this should be a positive thing. I think cooking at home, you can control what goes into your food. It's a good social bonding time with friends and family, so I try to spend this one as a positive. And weight loss. Sometimes when people aren't absorbing nutrients, they're malnourished, they don't need to lose weight. So sometimes with this diet, people find themselves who don't need to lose weight, you can actually lose weight. So other considerations, again, really important to identify and remove exacerbating factors. Supplementation, I'm going to mention a few things on. Ways to promote motility, we're going to talk about. And then again, what does maintenance look like? So some of the exacerbating factors, the obvious, which we've already mentioned, sometimes food sensitivities. Was there an illness, infection, environmental exposure? What's going on in your environment that can contribute to some of these symptoms? Inefficient digestion, have you had a surgery? Again, the goal is to decrease and eliminate inflammation overall. So another thing I wanted to slide in here, there's a lot of talk on gluten. What's up with celiac versus gluten sensitivity? Should we all avoid gluten? And one thing I like to talk about, I think Dr. Davis actually has heard this doctor speak. His name is Dr. Alessio Fasano. So he's wonderful to listen to lecture. He's got a great thick Italian accent and a good head of hair and very smart man. So he studies this area. And so he's found some enzymes that gluten can trigger that can actually affect the integrity of the tightness of these gap junctions in our gut. So these enzymes that can be triggered by gluten can actually make our gut somewhat leaky, if you will. These tight gap junctions, we should have this good solid gut barrier, and gluten, what he's found in his research, can actually affect that. So, another thing I present to patients is that I can think of a lot more food options that I can argue are much more nutritionally dense and beneficial than some of the gluten-containing things. So that was one little feed out there I wanted to give for gluten. Should we avoid gluten? So supplementation are going to include things like Prokinetics, which means we want to support that normal gastric movement, so that's important. We want to replace micronutrients, those vitamins and minerals that we need for optimal health and function. We may want to give things that are anti-inflammatory to bring inflammation down. We may give things like specific probiotics to help support your normal microbiome. And then also sometimes people need the addition of things like digestive enzymes while we're healing this process. So one thing that doesn't cost any money from a supplement standpoint to help improve movement in the gut is to fast between meals. So going back to that question of do you snack or graze all day or do you eat 3 meals a day? So we can actually disrupt that normal gastric motility or that movement if we graze all day. So a lot of times we'll actually recommend with this that you can increase that gastric movement if you don't snack or graze throughout the day. So that's one thing to consider. Prescription, we can do low-dose naltrexone. That has been shown to be helpful to increase gastric motility. And then from a natural option or a nutraceutical product called Modal Pro, which contains a B vitamin, which is what P5P is, ginger, acetyl-L-carnitine, 5-HTP, and vitamin C. A very nice blend for encouraging normal movement. Okay, so good multivitamin is typically recommended, especially initially because we're removing some of these foods. So we want to make sure you're getting all the good micronutrients that you need. Fish oil is a great anti-inflammatory, very healing for the gut. L-glutamine. Glutamine is food for your cells or enterocytes that line the gut. Very healing, and it's also SIBO safe, meaning that it's not a type of carbohydrate that's going to potentially feed some of those bacteria that we don't want to grow. Again, a probiotic, very anti-inflammatory, good for the immune system, helps strengthen the gut lining. Acetyl-L-carnitine, which was actually in that previous product, has been shown, we actually have scientific data that it's very helpful for healing nerves, also supports motility from that previous product. And then digestive enzymes can sometimes provide people with some initial relief as well. Yeah.
I think I've heard that are there probiotics that actually feed SIBO and about that, correct?
Yes, yeah, we do typically recommend a specific probiotic. One, just in general, what you'd want to look for is one that does not have prebiotic, because sometimes probiotics will come with prebiotics, or they'll say it's food for the probiotic, and the prebiotic part can actually cause people to have symptoms and not be helpful. So we do actually recommend a pretty specific probiotic. And I do have a good source that I share with people if you're looking for SIBO safe supplements, what else is in your medicine cabinet that may be contributing to this. So that's a great thing to look for. So just to wrap up, and then we can hang out and I want to answer your question about leaky gut, and you guys can ask more questions. But what maintenance looks like, it's not just treatment and then we're done. You're all better. More realistically, the process is very long, it's involved, and it's very individual. Like everything really should be very individual, not necessarily long and complex, but very individual. So many people do well if they continue on somewhat of a combination between the SCD and FODMAP, low FODMAP diet. And a lot of times what happens with people who relapse back to having the uncomfortable symptoms, it usually, when things are going great, we kind of get more laid back and we kind of go back to our old eating habits. Yeah, and then you got your symptoms back. Sometimes the Prokinetic is not just like on it for a week or two. Sometimes you can be on it for up to a year. And the supplementation, most people do well on continuing with a multi and fish oil, just very basic supportive nutraceuticals. So that's, again, wanting to put a positive spin, but also be very realistic with people of what to expect. This is something that's, again, very, very comprehensive and can be very complex.